My name is Ian McCall, and this is tutorial number 2 in the Ken Paver lecture series. Okay, what are we going to look at here? We're going to certainly look at ulcers and look at lymphadenopathy. And we've said we're going to ask some questions on these conditions: epithelioma cuniculatum, atrophy blanche, pyoderma gangrenosum, calcinosis cutis, Durkheim's disease, dermatitis artifacta, Bazin's disease, Orff, Behçet's, and herp angina and hand, foot, and mouth. Let's first of all look at ulcers. It's, the major ulcers you're going to see are going to be the traumatic ulcers, the venous ulcers, the arterial ulcers, and the neuropathic. You're not often going to see neuropathic. You're mainly going to see venous and traumatic ulcers. Venous ulcers obviously are associated with varicose veins. Usually you have either an incompetent von Saphenous vein, or you've got incompetent interconnecting veins, perforators, which connect the superficial venous system of the leg with the deep venous system. And these valves usually work one way, taking blood from the surface into the deeper veins, and then muscle contraction pumps the blood back up to the heart. But if these perforating veins, if the valves and nose closed, then every time the muscle contracts, blood comes up into the surface again, and you get veins, varicose veins. And ultimately, you get varicose ulcers. A varicose ulceration is seen around the medial aspect of the ankle, the medial malleolus. But often prior to this, you get a phenomenon of capillaritis, where the increase in pressure in the small capillaries leads to leakage of red blood cells and the deposition of hemosiderin from the iron in the red blood cells. That gives you that brown, peppery-like distribution of pigment that you'll see sometimes in the insides of the ankles. Over time, the skin is slowly damaged, and a venous ulcer may occur. Ken Paver, if you're trying to think of a mnemonic to use in encompassing an approach to all ulcers, then Ken used to use the acronym OSTAIL, where A stood for arterial ulceration, U was for undermined. We'll come to that in a minute, but undermined ulcers are particularly pyoderma gangrenosum. S is the surrounding skin. To some extent, what it's meaning there is if there's disease in the surrounding skin, ulceration may occur. For instance, conditions like necromycosis leukoidica. T is for trauma. The other T is for tumors. Remember that. I really should have said that's one of the common causes of ulcers you're going to see as well. In fact, in Australia, it may even be the commonest. If you see a chronic ulcer in the lower leg, and you think it's venous or what have you, but it's just not healing, they don't have much in the way of varicose veins, then consider that it may be an ulcerating BCC. A is for anesthesia. If you get any type of peripheral neuropathy, in the old days it used to be syphilis. Nowadays it's diabetes, and you get diabetic peripheral neuropathy, then you're liable to get, initially trauma-induced ulcers, and then neuropathic, what we call neuropathic ulcers, typically in the soles of the feet over, say, the heads of the malleoli. I is for infection. Sure, infected ulcers, particularly TB, Vibrio, that you might pick up from a stream. Mycobacterium ulcerans, Buruli ulcer. Certainly you've got to consider those if you're thinking of infection. And L for lymphadenopathy. Well, I'm presuming he's meaning that the ulceration is associated with lymphadenopathy. Again, you'd need to consider malignancy, but you'd also need to consider the infective causes, such as syphilis, such as lymphogranuloma venereum, where you may have ulceration and marked lymphadenopathy, and granuloma ingranale. Now he's subdivided these. He's looked at arterial, maybe subdivided to A, B, C, D, and E. A is for arteritis, okay, particularly Wegener's, polyarteritis nodosa, giant cell arteritis. It's rare to get a big temporal ulcer from giant cell arteritis. Polyarteritis nodosa, certainly ulceration get with those on the lower legs. Vegnas, you'll certainly get ulceration as well, and often it's in unusual places with Vegnas. Remember, Vegnas gives you renal problems. It tends to give you a C-ANCA positive. And watch for it if ever you see a chronic ulcer in the back of the mouth. Vegnas can do that. B, blood and bites. Okay, cholesterol emboli, things in the blood blocking little vessels and causing ulceration. Particularly that's going to be in the lower leg, particularly in the sole of the foot, and you may get surrounding libido as well. The dysproteinemias, again, that's just immune complexes. Disseminated intravascular coagulation. Ugh. You don't want to see that. It's usually meningococcemia, so you don't really want to see DIC. And thalassemia. Here it's the abnormal red blood cells that block the blood vessels and cause ulceration. But I don't think I've ever seen, at least I've never diagnosed thalassemia on the basis of an ulcer. C is for cold. Sure, if you have cold agglutinins, cold precipitants, they can give rise to ulceration. But again, it's immune vasculitis almost. D is drugs causing ulceration. Ergot. Vasospasm. Halogens. Don't see that much nowadays. Methotrexate causing ulceration. Does, again, we don't see it often though. And the other E is emboli, A, B, C, D, and E, for the arterial ones. Undermined, we've said particularly pyoderma gangrenosum and decubitus ulcers. Now these are usually pressure-induced ulcers, particularly on the buttock area, and you get ischemic necrosis of the central parts and some undermining as well. So, and they can come on suddenly, so you might confuse those two. You know, pyoderma gangrenosum, I think we'll come to it later, but you're going to see that in patients with ulcerative colitis, Crohn's, some arthritic disorders, both seropositive and seronegative, myeloid disease, myeloproliferative disorders, chronic myeloid leukemia. Surrounding, AUSS for surrounding. So surrounding damage to the skin, particularly venous stasis and necrobiosis lipoidica. Oh yeah, radiation. You know, if you've had radiation to an area, then over many years, 15 to 20 years, the center of it may start to break down, you get a radiation ulcer. And if you get any trauma to an ulcer, to an area that's had radiation, it's more likely to ulcerate because the vessels are damaged. Tumors, all types, plus calcinosis cutis. I think we'll come to that later. The only time I've seen ulcers due to calcium was in scleroderma, where a guy had marked deposition of calcification under the skin, and these plates of calcium would break through the skin surface and give rise to ulceration. Trauma. Yeah, look, we tend to forget about dermatitis artifacta. This is where someone's induced the ulcer, and it can be a difficult one. The lesions usually look really atypical, but don't forget dermatitis artifacta for ulceration. I mean, if you really think that it might be dermatitis artifacta that's causing an ulcer, wrap the thing up in a Una's boot, or get an Ixapaste bandage and wrap that right around it and leave it on for a couple of weeks so they can't get at it, and then you should see healing will occur. Heat, sure, that can cause ulceration, cold damage, electricity, electrical burns, sort of lightning as well. Anesthesia, yeah, we said the trophic ulcers and secondary infection usually. And leprosy, yeah, I mean, that's probably one of the commonest causes. You know, I talked of anesthesia in the past, nerve damage due to syphilis, and then I mentioned diabetes as being one of the common causes, but some parts of the world, leprosy is still around, and, tuberculoid leprosy especially will damage nerves, and they can get anesthesia from this, and then they get the ulcers, the secondary infection in the lower legs, and lose a foot because of it. Then infection causing ulcers. I mentioned atypical bacteria. I mentioned Vibrio that you might pick up from a shellfish injury if you've been walking in an estuary. And what's the other one that gives ulcers? Watch Pseudomonas. pyoderma gangrenosum due to Pseudomonas, that would be the ulceration. And so another one I was thinking about. Yeah, mucor. If you've got someone who's immunosuppressed and they're in hospital, then sometimes you can get a little yeast organism called mucor, M-U-C-O-R, that can cause a necrotic area of skin and subsequent ulceration. Then anthrax typically causes the necrotic area of the skin first of all. Lymphadenopathy we mentioned earlier on. Some of the, particularly the genital ulcers that can be associated with lymphadenopathy. Then pyoderma gangrenosum. I want to make a particular mention of it because you're liable to, because of all the number of cases of Crohn's and ulcerative colitis and so down rheumatoid arthritis and what have you, you're likely to get these sort of patients referred to. The thing about pyoderma gangrenosum is the ulcer comes on very quickly, and it may start initially as a reddish nodule and pustule, and sometimes as a hemorrhagic fluid that breaks down, and then it gets the characteristic undermined edges. Let's have a quick look at this image here. It looks as if there's been some healing occurring within this one, but you've got this ulcerated lesion here, and there is a degree of undermining. You need to look at that edge there to see the degree of undermining that's occurring, and this has been increasing in size quite quickly. We do have some better pictures of this. Let me just flick into Global Skin Atlas. Have a quick look at this one, because this was one of mine. Young lady with Crohn's, and she presented with, and it really did look that bluey sort of colour. It's the most curious sort of ulcer. But this was all undermined. This was the edge of the epithelium here, but it was all undermined underneath it. And we took a big incisional biopsy across this. If you're going to biopsy these, don't do a little punch, do an incisional right across it, so they can get a look at the edge, the normal skin here, and the ulcerated area here, because the pathology isn't all that specific from this. And then I think we say here the last images show it after 3 weeks of high-dose oral steroids. Let's flick up to this. It's still doesn't look dramatic, but at least there was some healing was occurring here in that ulcer, and it slowed down the progress of it as well. Well, actually, we might go back there. Let's just flick back to the diagnosis page. You can see some of the others here. By the way, that version, that variant that you're seeing here on the dorsum of the hand with these blisters, sometimes we describe this as sweets. It's all in neutrophilic infiltrate. You can see how this is ulcerated, and these sorts of lesions are typically seen in patients who have an underlying myeloid leukemia. So always watch for that in those sorts of patients. There's another more classic pyoderma gangrenosum there. I think we can see. Let's look at full size and just see if we can see the degree of undermining. You see how it's extending all the way out here? See the outer limit on this? And there's undermining all the way around here. You can see one here that is it just starting, or is it healed? It may heal with some hyperpigmentation. Let's see what that patient had. I can't remember. Diabetic woman, granular base undermined published border, 1 year duration. It's quite long for it. Yeah, previously healed ulcer nearby, so that was the healed one. They said skin biopsy was compatible with pyoderma gangrenosum, but essentially it just means that all the studies were negative for infection, and it wasn't a malignancy. And sometimes it's really just a diagnosis of exclusion rather than any other obvious histological features of pyoderma gangrenosum. A bit of that tissue, by the way, should always send for culture as well. I spend too much time on that. Okay. So, where were we? Am I on the right one? I don't think I am. My apologies. So, pyoderma gangrenosum. yeah, that little comment there. Note the patients and their doctors often diagnose this, the initial use of this as a spider bug, because it's painful, sudden onset. I've said consider factitial ulcers in the differential. Usually your patient's got a strange affect, you know, they're funny patients if you're really going to have to consider that. And if they've got a background of Crohn's, ulcerative colitis, you know, they've got a precipitating disorder, potential precipitating disorder, then it's much more likely that it's associated with that disorder. What underlying conditions are associated with it? We come to that in a minute. I'll show you those questions at the end. Next topic, epithelioma cuniculatum. Cuniculatum means like a rabbit burrow. And this is a curious lesion. Epithelioma suggests that it's some form of epithelial tumor, like a rabbit burrow. Don't have a good picture, but it's really, it looks like a really bad plantar wart, a really big plantar wart with some sinuses associated with it. But what it really is a form of squamous cell skin cancer, and it's verrucous in nature. In the past, people used to use radiotherapy, you know, for bad plantar warts, but you don't want to use radiotherapy. I mean, it's an oncogenic papillomavirus that really causes this. But if you try radiotherapy for these, you can get anaplastic transformation. We said that lymph node metastasis is rare because when this thing grows, it grows in a pushing fashion. It pushes down into the tissue. It's almost just like a wart does. You've got to do a deep biopsy if you're going to do a biopsy in one of these, not a little superficial one. You've really got to do an incisional biopsy, and it's never a great thing to have to do in the sole of the foot. Have a look at that one elsewhere. You do not get venous ulceration on the sole of the foot. This is true. If you've got an ulcer on the sole of the foot, it's either arterial or it's neuropathic. So venous ulceration should be open-medial malleolus. Let's just have a little glance at this e-medicine thing and see if it's got any pictures here. Not sure if it will have. Yeah, it's just going to slow going, well differentiated SCC, minimal metastatic. Yeah, the other thing about this, I've said epithelioma cuniculatum is the name given to verrucous carcinoma when it involves the sole of the foot, but it can also involve the oral cavity, it can involve the larynx, it can involve the genitalia, and the esophagus. So perhaps have a little look at that in your own time. Now let's have a look at this image. This, I've said this is verrucous carcinoma at the inside of the mouth. They're often a lot more papillomatous than this, and sometimes we get the name floridoral papillomatosis. There's a Buschke tumor that's associated with this as well. I've given that name. But you can see leukoplakia here. Usually, as I say, it's more verrucous, more papillomatous. But it's an oncogenic virus, that papillomavirus that causes it. That would need biopsy, obviously. Calcinosis cutis, deposition of calcium in the skin. We've said this condition is divided into 4 forms. The dystrophic form, the metastatic form, the iatrogenic and traumatic form, and the idiopathic. What about dystrophic? Where are you going to get that? Serum calcium and phosphate levels are normal. In the metastatic form, serum calcium and phosphate levels are raised, and they'll be raised in conditions such as hyperparathyroidism, sometimes also sarcoidosis. You can get raised calcium levels, and you may get what's called metastatic calcification then. Iatrogenic calcinosis, seen with medical procedures, leakage of infusions or injections of calcium with local elevated calcium levels. Sometimes that can occur in infants when they have calcium infusions or the like given through drips, especially scalp cannulae. And then idiopathic calcinosis cutis, where there's a normal serum calcium. Well, it's the same with the dystrophic one as well. We don't really know what starts off dystrophic calcinosis. Maybe local trial was this? Yeah, miliary osteomas. If you're going to see those, they'll present as, in a woman, usually on the face, multiple small, very firm little subcutaneous nodules. They're actually little papules, they're not big enough to be nodules. But if, say, they've taken tetracycline because of preceding acne, because sometimes this can follow acne damage to the skin, then the osteomas may be pigmented. So they may look a purpley sort of color or bluey color. And they may fluoresce with ultraviolet light. So miliary osteomas. Have a look at these. I find this topic quite difficult at the best of times, just knowing whether something is in the idiopathic class or the dystrophic class. Now I said there, differentiate the following: cutaneous calculus, osteoma cutis, and pilomatrixoma. Cutaneous calculus, yellow-white, single, often on the face of children, and it's hard. Tumoral calcinosis can look very similar. I remember getting a case from my findings that they showed me the x-ray. It was a short case, but they used to run an x-ray out to show the solid bit of bony calcification in the skin. Osteoma cutis, very small grouped bone in the skin, often picked up in x-rays. This is true. And pilomatrixoma, this one you're going to come across. Now, if you're looking at benign tumors in children, 80% of them are going to be, well, I'm sure if that's true, I think 60% of them are going to be pilocysts. 20% of them are going to be pilomatrixomas. And the other 20% are going to be a mixture of other things. So you're going to see pilomatrixomas. Usually on the face or the forehead, skin colored, maybe lobulated. Again, very hard. You think initially this is a pilocyst patient's got, but when you go and feel it, it feels really hard. And that's because of the deposition of calcium in the lesion itself. They slowly get bigger. This was a little picture of calcinosis cutis. Just a bony calcium deposited in the skin. What about Bazin's disease, erythema induratum? The two you're going to have to compare are erythema nodosum and erythema induratum. Erythema nodosum, red, non-scaly, painful nodules, front of the shins, a little bit of surrounding hemorrhage associated with them. It's a paniculitis, and it's what we call a septal paniculitis. In other words, the vascular damage, the inflammation is in the septum. That's where the vessels are. The lobules are fat, still okay. Erythema induratum, that's on the calves, usually in fat women. The lesions again present as tender red, non-scaly nodules. Sometimes they rupture onto the skin surface and break and exude altered fat material. But this, if you look at it histologically, it's a lobular paniculitis. It's the fat lobules where the inflammation is involved rather than the septum. And there may be a degree of vasculitis associated with it because it sometimes goes under the name of nodular vasculitis or Bazin's disease. Erythema induratum, middle-aged women, posterior lower calf, indurated, sometimes ulcerated areas surrounding acrocyanosis, right, rather than bruising. Most of the damage in this condition is occurring in subcutaneous fat, lobular paniculitis. Yeah, granulomatous inflammation occurs in about 60% of the cases. Fair enough. And vasculitis can also occur. We must have a case here in Global Skin Atlas. Let's have a quick glance. There we go. See, it's on the calves rather than the shins. There's a nodule here. No real ulceration as such, is there? Obese woman, tender brownish red to purple film nodules and plaques, some adherent to the overlying skin, some scarring and ulcerations. 1 year duration. Skin biopsy shows a lobular paniculitis with many tuberculoid granulomas. See, at one stage this was thought to be one of the sort of reactions you get with tuberculosis. Not any longer. But remember we said 60% of them may show granulomas, tuberculoid granulomas. Shown here. If we can just have a quick only other thing that can be a paniculitis that will give you a bit of superficial scaly involvement like that may be lupus paniculatus, which also will give a lobular paniculitis, but there may be overlying changes of lupus in the epidermis. That's why you can get epidermal changes. So you'd want to biopsy that. You'd ask if it's Bass's disease or if it's lupus paniculatis. Okay. Dermatitis artifacta. We said that usually the lesions are grouped and usually they're abnormal in shape. Usually occurs in crops. Yeah, now that's important. It's an important differential point. You know, they injure the skin, have a break, these lesions partially healed, then they injure your skin elsewhere, and so you've got fresh and healing lesions. So look for that. Usually the ulcers in this are going to be very superficial, but it depends on what's being used to create them. The more caustic compound used, the deeper the ulcers will be. I mean, there's been a few classics of this. I remember in my very early days, Waldoloni had a patient, a lady, who had an ulcer in the back of her pharynx. And Wall, being the very good dermatologist he was, thought that she in fact had Wegener's, and had her in for Wegener's, which had a strange affect. And subsequently she was found with a mirror and a paintbrush and some caustic compound that she was painting on the back of her throat, and it became then obvious that this was a dermatitis artifacta. Patients can sometimes do funny things, but normally they'll have a strange affect. Now this was a lady here, and this was a young girl, you know, had these triangular lesions. They look as if there was a bit of hemorrhage into the skin here as well, but they were just in her anterior chest wall. She was one of my patients in Hobart. And when I looked at these, I thought she had dermatitis artifacta, but her mother went ballistic. Subsequently, she was admitted to one of the local hospitals in Hobart, where they actually found her injuring her skin and watched her doing it, inducing these. And subsequently, she was then discharged, and I saw her mother, who just smiled as I walked past. Didn't say a word to me. Anyway, look, it's tough. I mean, there's obviously the kid had some psychological problems and was doing this. It's really a case of trying to find out what the issue is, trying to help her. ORF. Oh, the other thing about dermatitis artifacta, watch it in nurses and people who have a bit of a medical background. They can inject funny things into the skin. And I mean, a classic with nurses used to be pentazocine, that one of the painkillers they inject under the skin that would give a good going sort of paniculitis-like picture. But it's been a funny area. What about ORF? Contagious pustular dermatosis. It's one of the parapox viruses. I'll say it's a pox virus. I think it's a parapox. And where do you get it? From the muzzles of orphan lambs or sheep. Usually it used to be the farmer's wife who would feed them, you know, bottle feed these orphan sheep. And of course they would be nuzzled around her hand, and she'd get, if they had orphan, she'd get it around the hand that she was holding the bottle with the teat. But you can also see it in farm workers, vets, or shearers. So if you're in the country, you're likely to see it. You're not likely to see this much in the city. And it's an interesting lesion. You know, I've said there they may resemble pyoderma gangrenosum. But, you know, this is, did I say pyoderma gangrenosum? Pyogenic granuloma, yeah, is what they may resemble. But this is a classic ORF. Now, it looks as if there's a blister there, but it's actually a pseudo-blister. It's because of a lot of edema in the dermis, and it's lifting the whole epidermis up. All the inflammation is in there. There is, you know, it's a very marked inflammatory reaction you get with ORF to this parapox virus. And the lesion has this pseudoblister appearance, and it may ulcerate, and it will evolve and slowly go within a 5 to 6 week period. Shelley used to believe that you could make them evolve quicker just by shaving them off, that they would in fact evolve and heal better. think this was in a bed. The others used to be the shearers, they'd put their arms round the sheep when they were holding it. And of course, if the sheep happened to have scabby mouth, then the vets would get it. If the vets even suspected that the sheep had anything like that, they'd refuse to shear them. We haven't got any drugs that make any odds to this. You just have to let it slowly resolve. Occasionally, some patients will get erythema multiforme when they have ORF as well. In other words, a few days down the track, 10 days down the track, suddenly come out with a rash of erythema multiforme. I think you should have some decent pictures of that. Let me just look at Global Skin Atlas for a minute. Sorry, I'll shut that one down. Is it there? Let me just look for ORF. The reason I think we'll have a lot in here of ORF is that one of our best contributors is Dr. Al-Sudani from Iraq. And of course, they handle a lot of live sheep over there. So they see a lot of ORF in patients. Whoa, the pictures of ORF we have here. That was mine initially. These are some others. Abs in the hands. They all look like big infected abscesses. This one here. That's almost like Sweets syndrome as well. That little Sweets that we saw early on, the pyoderma gangrenosum condition, neutrophilic dermatosis. Look at them all. See how they all present as these big blisters. If you've got time, go into Global Skin Atlas, have a little look at the various examples of ORF that we have there. Behçet's. What sort of ulcers are you going to get in Behçet's? Well, typically your ulcers are going to be oral, and they'll be abscess-like, big, but multiple abscess-like ulcers inside the mouth. But of course, they can also get ulcers elsewhere in the skin and genital ulcers as well in Behçet's. But we said skin lesions can take a variety of forms, including ulcers, pustules, features of vasculitis, recurrent cellulitis, erythema nodosum. Recurrent superficial and deep thrombophlebitis, pustules after venipuncture. Yes, one of the causes of pathogy. That's the phenomenon of a pustule developing at the site of trauma of the skin, particularly say a venipuncture and the like. And you'll see it in Behçet's, you'll see it in Sweets, you'll see it in pyoderma gangrenosum. You may get follicular papules or pustules, hidradenitis suppurativa, or pyoderma gangrenosum as some of the cutaneous manifestations in Behçet's. Usually it's some form of genital ulcer, skin ulcer, perhaps eye lesions and oral ulceration that would make you think of Behçet's. An interesting fact to remember is that causes of recurrent cellulitis include Behçet's, lymphedema, familial Mediterranean fever, right, and Wells syndrome. They're all, that's an eosinophilic cellulitis, Wells syndrome. Familial Mediterranean fever. Is that a form of amyloidosis? I need to look that up. You can look that up. Find out what familial Mediterranean fever is. Of course, the commonest cause of recurrent cellulitis is because somebody's diabetic, they're not looking after their skin properly, and they get recurrent infection because of that. They might have tinea between their toes. These are rare causes of what seems to be recurrent cellulitis. However, useful thing to remember. These were oral ulcers in Behçet's. Multiple big abscess-like ulcers. Being a feature of Behçet's syndrome. How would you differentiate herp angina and hand, foot and mouth disease? Well, off the top of my head, obviously, herp angina is only going to affect the inside of the mouth. And from my experience, it's usually the soft palate that's involved, the tonsillar pillars. And they get punched out, little ulcers, round little ulcers like that. Whereas hand, foot and mouth disease, the ulcers tend to be at the tongue and also the soft palate, and they're linear. But I've said here that herp angina usually affects the pharynx. Well, a few cases I've seen, it's been the soft palate that's primarily been involved. certainly it doesn't have the linear vesicles that hand, foot, mouth does. And obviously, you examine elsewhere if they've got lesions in the hands and feet, and they've got hand, foot, mouth disease rather than have angina. I think they're all Coxsackie type viruses. This was just a little photograph. Well, it's hardly elliptical, is it? It's fairly round. Any elliptical ulcers here, or elliptical vesicles. To get a better example of that phenomenon. Occasionally, even with hand, foot, and mouth, you can get the lesions occurring elsewhere in the body, but they're primarily going to be in those areas. It's quite infectious too. Classification of lymphadenopathy, either localized or generalized. Right. Certainly generalized lymphadenopathy, you go looking for underlying lymphomas or leukemias. Localized, you're looking for draining infection of some sort. If it's tender, it means rapid growth of an infection. Yep, okay. Consistency can be rubbery, the lymph glands can be rubbery, stony hard, or liquefactive. Well, the latter is certainly associated with TB. Stony hard would be metastases, I would have thought. And rubbery, I think sometimes lymphadenopathy and syphilis is described as rubbery. If the skin over lymphadenopathy is inflamed, it usually means there's an infective disease in the gland. I agree with that. So it's either TB or one of the genital disorders, particularly lymphogranuloma venereum. If there's matted lymphadenopathy, usually it's either TB or lymphogranuloma venereum. Fair enough. Okay, this was cutaneous TB. Now, remember there's a level of resistance here. You might look at that and think, oh, there's little erosions here, there's just a big patch of discoid eczema. But the history would be it's been there for some time. And these are, in fact, areas of scarring where healing's taking place here. But it's a very well-defined edge, isn't it? Usually an eczema is quite as defined as that. But it'd be the history of a patch being there for 12 months. I certainly wouldn't respond to topical steroids. Do a biopsy. And an incisional one across the edge of that. Differentiate arterial and venous ulcers. Well, I suppose site. Venous, particularly in the medial malleolus, arterial tends to be the larger malleolus. You don't get venous ulcers in the sole of the foot, you get either arterial or neuropathic ulcers there. And you've usually got surrounding skin changes in venous ulcers. And they have a sort of beveled shoulder to them. They don't have the sharp edge that you see with an arterial ulcer. So arterial ulcers are usually deeper, punched out, often with slough in the base, little of an inflammatory reaction round about. Venous ulcers are usually shallow, granulation tissue in the base, the pinkish, sloping edges, and often surrounding inflammatory response. Thalassemia, we spoke about earlier. It's usually on the foot, chronic, superficial. Small blood vessels are blocked by red cells, which cannot distort to fit the vessels. That's the problem. The red cells are an abnormal shape in thalassemia. And then atrophy blanche. It's atrophy blanche. Let me show you a picture. This is a picture of atrophy blanche down here. Usually the patients have chronic venous problems. They usually have that brownie surrounding pepper-like pigmentation from capillaritis, from leakage of red blood cells in an ugly position. Then you've got this white scarred-like area, and there may be some little telangiectatic areas within that as well, and that's what we call atrophy blanche. Typically in the inside of the ankle, like this, surrounding skin may well be hard. There may be a degree of lipodermatosclerosis there, with collagen and scarring under the skin. And you don't want to biopsy these because they're just the devil to try and heal. But what have we said here about atrophy blanche? Probably better named livedoid vasculitis. but occasionally it does show leukocytoplastic vasculitis. Small, painful, purpuric eruptions slowly heal with these stellate white scars, and these are what are called atrophy blanche. May also be telangiectasia, a bit of ardent pigmentation, that's that pigmented purpuric dermatosis round about it. Sometimes even livedo. Venous stasis is probably the main cause of atrophy blanche. But they sometimes have fibrin problems as well, and livedo vasculitis is a vasculopathy, a chronic recurrent, sequential, hyalinizing vasculopathy in small blood vessels. Yeah, if you do immunofluorescence, you may see fibrin, IgM, and C3 in the vessel walls. So, yeah, some of these patients, from memory, I think if they have this, like with dermatosclerosis, they were also treated with stanozol, which was an androgenic steroid, and it was responsible for trying to reduce the vasculopathy that was occurring in this condition, but yeah, I don't really understand it. Venous ulcers, yeah, we said you don't get venous ulcer in the sole of the foot, and also there's either arterial and neuropathic, and Dirk, what are we finishing up with? Dirk's disease, adiposis dolorosa. I don't think a good picture of that. Obese menopausal women, symmetrical, tender, fatty deposits, particularly on the thighs. Right. Symmetrical, tender, fatty deposits usually in the thighs. The presence of these is sometimes associated with weakness and psychiatric disturbances. The lesion is usually referred to as a bag of worms, which subsequently ulcerates. Well, I can't say that I've seen a case of Gherkin's, but adiposis dolorosa seems like a good name for something that's going to be appearing as a bag of worms on the thighs that's subsequently going to ulcerate. Wonder if we get anything in e-medicine on this one. Okay. Progressive syndrome, unknown etiology, multiple painful lipomas, rising in adult life, postmenopausal women who are obese. Pain is out of proportion to the physical findings. It's described by patients as all fat hurts. Okay. That's obviously an interesting disorder. Just remember it, outer aspects of the thighs, painful bag of worms. We don't appear to have any obvious pictures associated. See if we have actually. Bear with me. No, we don't seem to have any pictures associated with this one. Medicines or dermatology anyway is full of most unusual diseases. Oh, by the way, that was a picture of some venous ulceration. Not so sure, well, it's fairly sharp edge. That's certainly a granulation tissue in the base surrounding chronic pigmentation changes, presumably features of varicose veins that have in fact caused this. So, and often they heal with a bit of scarring and the like, and we get atrophy blanche from the healing process as well. Well, it's taken a long time to go through all of those, but there are some interesting conditions there. There are some questions that are there. If you want the answers to these, by the way, put some text in there. If you're lazy, just put text in and press submit and you'll get the answers. But the idea is to actually have